With fresh embryo transfer, I would say the most important thing that patients need to remember is that we have to start progesterone supplementation on the evening of egg retrieval. It's really important because we really want to prepare the endometrium for the embryo transfer that is going to happen either day 3 or day 5 into that cycle.
Yes, I agree. Progesterone is such a big deal when it comes to the success of an embryo transfer. And we talk about the progesterone because this is something that you can control as opposed to so many other things when it comes to fertility. Welcome to my fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together. On today's episode, we are revisiting fresh embryo transfers. So this is part 2 of our series on fresh embryo transfers. Now, for those of you who are interested in learning more about frozen embryo transfers, you can have a listen to episode 68, where we go into depth all about that. In our previous episode on fresh embryo transfers, which was episode 67, we discussed the process, some of the timelines, as well as some of the pros and cons of fresh embryo transfers. On today's episode, we're going to be talking about success rates. We're going to be doing a bit of a compare and contrast between fresh and frozen transfers, as well as answering some frequently asked questions, including which progesterone is best.
Now, just to make it easy for you, because fresh embryo transfers and frozen embryo transfers would be what comes after an IVF cycle, we do reference different IVF episodes throughout this series. These episodes about IVF that were referenced would be episode 14, episode 20, 54, and 58.
All right, so without much further ado, let's get into it. When we're thinking about embryo transfers or when we're talking about embryo transfers with patients, one of the most common questions that always comes up is, what are the chances that this transfer is going to work? And there's a couple of different ways to think about this question and to answer this question. So we're going to go into a pretty in-depth discussion about this.
Yeah, so in general, success rates for fresh embryo transfer vary a lot depending on age, embryo quality, and of course, the experience of the clinic where you're doing your IVF cycle. On average, the live birth rates are between 30 and 50% per embryo transfer in women under 35 years of age. And this would be assuming that you're transferring a good quality embryo. We should probably actually do another episode on embryo morphology, but just in general, good quality embryos would be an embryo that becomes a blastocyst on day 5, usually graded A or B, or anywhere between a 3 or a 5, which has to do with the size of the embryo. When you're having a day 5 embryo transfer, and let's say the embryo is not a blastocyst, let's say it's an A cell embryo on day 5 or is a morula, then that definitely can decrease the chances of pregnancy because it might be an embryo that it's not developing properly.
At the end of the day, this is really just an important question to ask your physician so they can give you a proper personalized answer to that question, depending on your own history and the embryo itself and your own fertility history. So let's talk about fresh versus frozen embryo transfers here, because this is a big question or a big decision that you're going to be making with your fertility physician in regards to which one you may want to do. Now, there are a couple of rules, but a lot of it kind of comes down to a matter of perspective and what's more important, because there are pros and cons of both. In a frozen embryo transfer, it's often better for many patients, especially those who have a high ovarian response. And again, in our frozen embryo transfer episode and in our part 1 of fresh embryo transfer, we talked a little bit about the risk of OHSS.
With ovarian hyperstimulation syndrome, the estrogen levels are usually very elevated, or even if you don't have ovarian hyperstimulation syndrome, if you're somebody that has good ovarian reserve that retrieve, let's say, 12, 15, or more eggs, there's a very good chance that you have a high estrogen level. And a high estrogen level can impact the quality of the endometrium and decrease the fresh embryo transfer pregnancy rate. So, in people who have a high ovarian reserve, who respond really well to the stimulation, who retrieve a lot of eggs, even if they're not having ovarian hyperstimulation syndrome per se, it is still recommended to do a frozen embryo transfer to avoid transferring an embryo in that very high estrogen environment. The good news is that once the fresh IVF cycle is completed and the patient gets her period, then that frozen embryo can be transferred into a lower estrogen environment, whether it is a natural cycle frozen embryo transfer or a medicated frozen embryo transfer.
Another reason to choose a frozen embryo transfer over a fresh embryo transfer, maybe if the endometrial lining is looking thin, or if it's not looking so good, or if there's fluid in the lining. It's often very difficult to predict what somebody's endometrial lining is going to look like while they're going through an IVF cycle. The vast majority of patients will have nice linings that are a nice thickness, that, will have a good appearance, that won't have fluid. But occasionally these things can happen, and they really only develop as the stimulation goes on. So if the lining is looking a little bit too thin, or if there's concerns about fluid in the lining, that would be another reason why we would err on the side of proceeding with a frozen transfer as opposed to a fresh transfer.
Another really great reason to do frozen embryo transfer is if you and your physician are considering doing preimplantation genetic testing, which we talked about extensively on episode 30. Preimplantation genetic testing has many benefits, and again, you should listen to that episode to go through that, but it absolutely has to be done in a frozen embryo transfer. So in this case, the eggs get retrieved, fertilized, and once the embryos become blastocysts, they get biopsy and frozen at the blastocyst stage, and then they get transferred into a future cycle. So if there is a reason to do preimplantation genetic testing, then a frozen embryo transfer would be the way to go.
In a frozen embryo transfer, there may also be more opportunity or flexibility to optimize the uterine environment and sort of the whole, let's call it pelvic environment, or the whole body environment. What I mean by that is that there are certain situations where we may be looking at doing some additional testing. Let's say in patients who have a history of recurrent implantation failure, recurrent pregnancy loss, and we may opt to do that additional testing instead of proceeding right into a fresh embryo transfer in preparation for the frozen transfer as well. And this is very patient specific and really depends on the individual circumstances of the patient and of the case. But again, sometimes we just want to take a little bit more time to do some extra stuff, let's say, before we're moving into an embryo transfer.
Has many benefits as there are to frozen embryo transfer, as we just described. There's also some downsides. For example, it does require a delay. So you have to do the IVF in one cycle and then an embryo transfer in a subsequent cycle. There are also extra costs involved. A frozen embryo transfer is an extra cost separate from an IVF cycle. In some clinics, they charge for a fresh embryo transfer. Some clinics do not. Markham Fertility Center does not charge extra for a fresh embryo transfer. So this is something that you might want to look into when you're considering clinics, just to be clear on the cost. But certainly, I would say every clinic would charge on a frozen embryo transfer. So there would be different costs associated with that, as well as new medications. Could be estrogen, could be injectables, could be letrozole, could be a natural cycle, but there would be a whole new protocol and a whole new set of medications introduced. It's also not ideal, and we're going to talk about that a little bit more, in patients who don't have a lot of embryos for transfer or who are having a hard time making blastocysts, either due to an egg quality problem or some other issue. So that is something to consider when deciding to do a fresh versus a frozen embryo transfer.
On the flip side, fresh embryo transfer may be a better option for certain patients. And in fresh embryo transfers, we know that they can lead to pretty similar success rates in younger patients who have a lower or normal ovarian response. There was this very recent study that was published actually this year that caused, I think, a lot of waves in the fertility community, in the fertility world, about fresh versus frozen transfers. This study was titled Frozen versus Fresh Embryo Transfer in Women with Low Prognosis for IVF Treatment. This was a multi-center randomized control trial, and it was published in the very fancy British Medical Journal, as I said, in 2025. In the study, they had 838 women. Again, it was a multi-center randomized control trial, which means that the evidence, that the conclusions from the study are going to be considered really strong. And so they were specifically looking at women whom they called having low prognosis for IVF. And they classified this as having less than 9 eggs at the time of retrieval, or an AMH that is less than 8.6 picomoles per liter.
Not surprisingly, this study concluded that the rate of live birth was lower in the frozen embryo transfer group, again, in this particular group of low prognosis for IVF, than in the fresh embryo transfer group. So the fresh embryo transfer group had a pregnancy rate of 40%, and the frozen embryo transfer group had a pregnancy rate of 32%. They did notice that there was no difference in birth weight or obstetrical complications or neonatal issues.
This study caused a lot of waves because I feel like the pendulum had swung so much in the direction of frozen embryo transfers over the last, like 5 to 10 years. Certainly at American Fertility Center, we've definitely seen an uptick in people proceeding with fresh embryo transfers over the last couple of years as well. And I think a lot of us sort of had this feeling that, like, in those patients who have a low egg reserve, where they may be only getting one blastocyst or no blastocyst, may be worthwhile to proceed with a fresh transfer. Because even if the embryo does not necessarily get to blastocyst or freezable quality, that there's something about putting it into the uterus sooner, maybe of some benefit, or that, we're now not putting that embryo, that blastocyst, through the potential stressor of the freezing and then the thawing. And then that's why we get a little bit better pregnancy rate. We don't really understand why. I mean, these are just theories. This is just me kind of speculating. But certainly, this study has definitely made me think about my own practice and how I counsel patients. And I certainly find myself doing a lot more fresh transfers.
Yeah, absolutely. Me too. And I think it's really important to not take the study out of context. It doesn't mean that
Mhm.
everybody should be doing a fresh embryo transfer. Oh, my AMH is less than 8.6. Therefore, I absolutely have to do a fresh embryo transfer because of that study. This is a really nuanced discussion, and you have to take so many factors into account: finances, psychological well being, prior experience, number of cycles. There's just a lot that goes into it. So it's a very detailed, nuanced discussion to have with your physician. But certainly, I completely agree. We went from not doing any fresh embryo transfers at all to doing more fresh embryo transfers. And I would say those are the typical patients that we do them in: patients that don't make a lot of embryos to begin with, patients that have lower ovarian reserve. If you're making one or two blastocysts to begin with, then exactly like you said, let's put it into the uterus as soon as possible and let the body do the PGT testing, so to speak, by allowing implantation and then proceeding from there.
And also, it's worth noting that, we talked about frozen transfers and the effect of these super high estrogen levels. And in fact, when patients have a lower egg reserve and they're not making as many eggs, they're not getting those crazy high estrogen levels too. So again, they're lower risk or almost no risk of OHSS, that ovarian hyperstimulation syndrome, and you're not having those super high estrogen levels, which maybe are affecting the quality of the lining too.
Mhm.
Because again, that's another question that often comes up.
That's actually a really good point, because every once in a while I have patients who have very good ovarian reserve and they come to me saying, Dr. Garcia, I really want to do a fresh embryo transfer. And I said, okay, yeah, we can do that. But if we're going to do that, then I have to give you less dose of medications, because I know that if I give you a standard dose with your high ovarian reserve, you're going to make a lot of eggs and you're going to have a high estrogen level. And I'm not going to be doing a fresh embryo transfer. So if your goal really is to do a fresh embryo transfer, which is fine, then you need to know that I'm going to have to give you a lower dose, which means we're going to have a lower estrogen level, which means we're going to get less number of eggs. And that is a real trade off. I'm not saying it's a bad trade off, In some circumstances, it might be a good idea, and there's a lot of reasons as to why that would be. But it's just really important to know that if you have high ovarian reserve and you want to do a fresh embryo transfer, there is that trade off. For patients that have low ovarian reserve, then unfortunately, we know that we're never going to be making the 15 to 20 eggs. So you're not doing as much of a trade off. You're already saying, well, the ovaries are only going to be making 4 eggs. The estrogen level is only going to get to this level. So, yeah, it's an ideal environment for a fresh embryo transfer in the first place.
Yes. Because again, estrogen levels during IVF are related to the number of eggs you make, not the dose of medication that you get, which often comes up a lot. All right, so let's move into some of the frequently asked questions that we get from our patients. So we're put it together into this FAQ style little segment here where we're going to be asking each other and explaining how we counsel patients about this stuff. All right, so Dr. Garcia, are you ready?
I'm ready. I was born ready.
You were definitely born to be a fertility doctor, that's for sure. All right, so patient says, can I work after the embryo transfer? What do you say?
You absolutely can work. And this is another one where the pendulum has sort of moved in different directions. I've been practicing for about 15 years. And honestly, when I did my embryo transfer 13 years ago, I did do bed rest at that time. And then when I did my next embryo transfer about now 8 years ago, I didn't. I was actually on call delivering babies, doing a 24-hour shift right after my embryo transfer. Right now, the current evidence says that you do not have to do bed rest, but you can work. But I mean, it is an emotional day, and we do recommend that you take it easy. Maybe work from home if you absolutely have to work. Maybe take a day off if you have some availability to do that. But you definitely do not have to be on bed rest. Here's another one for you. Patients who have been trying to conceive tend to be very in tune with their body. They know when they're ovulating, they know when they're getting their period. It's completely normal. And some patients are worried that when they do an embryo transfer, they don't feel anything. Therefore, they think that might have an impact on their chances of getting pregnant. What do you think about that?
So, after an embryo transfer, it is very, very normal to feel not much of anything right away. Some people might have some very kind of slight, very mild, I won't even call it cramping, but maybe like tingling, let's say. So, that they feel that something is going on, maybe if you really, really focus in on it. Again, many people feel a lot of nothing right after the transfer. You may have a bit of spotting. Again, very common. That's really more from the cervix and just putting a catheter through the cervix. Some people have very friable or very fragile cells on the cervix. And so even when you touch them, they can just kind of bleed like a tiny little bit. Again, super normal. Bottom line, though, is that whether you feel something or not, it really does not predict whether your transfer is going to work or not. Even, people who are looking for those pregnancy type symptoms as they're waiting, let's say doing that 2-week wait, as they're waiting for their first beta, the vast majority of patients, I would say, do not have sort of those pregnancy associated symptoms like, let's say, nausea, fatigue, breast tenderness, that kind of stuff. Now, this does get muddled a little bit in the world of fresh embryo transfers because not only are you pregnant until proven otherwise, but you're also recovering from a retrieval. So 5 days out from the retrieval, when you're doing the transfer, you may still have some bloating. You may still have a bit of nausea, potentially from some of the hormones as you're kind of coming down off of them from the stimulation. So there's just a lot of things that are going on in someone's body when they're doing a fresh embryo transfer. I really would not be using those symptoms as what you're feeling to predict whether the transfer worked or didn't work.
Yeah, I mean, the 2-week wait is so hard because maybe you're feeling something, maybe you're not. You don't know what it means. Of course, you might have partners or your mom or friends being like, well, did you feel anything? Did you feel anything? And that could be really stressful. At the end of the day, the only way to know is to do a pregnancy test. Some people can choose to do a home pregnancy test, which you can do as early, I'm afraid to say, but in reality, as early as 6 days after embryo transfer, maybe even 5 days after embryo transfer. If it's negative at that point, it doesn't mean it didn't work. So you might need to keep repeating. But the pregnancy hormone test that we do at the clinic is normally done about 10 to 12 days after embryo transfer. And that is when we officially know if the embryo implanted or not.
All right, another question here for you. With a embryo transfer, should I do acupuncture? Should I take supplements to help increase the likelihood of success?
The data on acupuncture is really mixed, and we actually covered this on episode 54, which was an episode about IVF and the extra little things that we can do on top of an IVF cycle to hopefully improve the chances of success. I tell my patients, if acupuncture helps you relax, if it's something that you enjoy, if it's something that feels good to your body, then absolutely I would say go for it. I don't think it's mandatory. I certainly don't want to add an extra cost and an extra stress and an extra step to patients who don't find it relaxing. And I think in terms of supplements, there really aren't any supplements that improve implantation. We talk about prenatal vitamins, which are very important with folic acid, decrease the risk of neural tube defects. We talk about that on episode 10 of the podcast. In the same episode, we also talked about vitamin D and omega 3, which are, again, they're not to help implantation, but to improve the health of a potential pregnancy. And then in terms of egg quality supplements, we've also covered that in previous episodes as well. And the main one that we use is coenzyme Q10. But no, there aren't any supplements that are specifically for improving implantation. Speaking of implantation, how about the question is, can I choose how many embryos to transfer? Can I transfer 2 embryos? Can I transfer 3, 4 to increase the chances of at least one of them sticking?
There is a general answer to this question, and there's a very Ontario specific answer to this question. So, what I mean by that is we're both fertility physicians who practice in Ontario. And so we have lots of patients who are doing IVF and they're OHIP or government funded IVF cycles. Specifically, in an OHIP government funded cycle, the government is very clear about the number of embryos that we can transfer at a time. It's one of the big rules that we definitely follow. And so the vast majority of transfers that are done as part of the OHIP funded cycle, we're transferring 1 embryo at a time. Now, there are certain circumstances, like if somebody has failed multiple transfers, then we can consider putting in 2. But the vast majority of the time, it's 1 at a time. Now, if it's a private cycle, like if somebody's paying out of pocket, or if you're somewhere outside of Ontario, then there's a little bit more physician patient discretion. That being said, in Canada, we still strongly recommend single embryo transfers for the vast majority of patients to reduce the risk of twins or higher order multiples. Certainly, a lot of patients who have longstanding infertility come to see us and they may say, you know what, I just want twins. I've been working so hard to get pregnant the first time. I can't even begin to fathom doing this a second time for baby number 2 or potentially even baby number 3 down the road. And I can completely appreciate that perspective. This whole idea of like one and done. But we're going to put our obstetrician hats on here for a sec. A multiple pregnancy, so twin or higher order multiple pregnancy, it is a higher risk pregnancy, meaning that there's higher risk of all the not good things. So higher risk that babies are born premature, higher risk that you need a C-section, higher risk of you having gestational diabetes, higher risk of you having blood pressure issues and preeclampsia, and all the pregnancy related complications. Essentially, the risk goes up when you're having more than one baby at a time. Our goal really is healthy mom, healthy baby. And so that's why we generally strongly recommend doing single embryo transfers here in Canada. And in fact, things like twins or higher order multiples are considered a complication of IVF, and they're actually tracked and they're considered a negative outcome or a bad thing. Now, again, we don't have perfect control over absolutely everything. I have definitely had many patients over the years where we've put in 1 embryo and it has split into 2, or people who get pregnant with twins despite us doing a single embryo transfer. It absolutely happens. But again, it's all about understanding what risks you're taking and measured risks. Again, not everything is in our control, so it does happen. But the safest thing is 1 baby at a time. All right, so now this is the big question. This is the one that we get asked most commonly, I would say, because obviously, if we're doing this single embryo transfer, we want it to work. So, Dr. Garcia, with all of your phenomenal years of experience and all your great knowledge, what can patients do to maximize their odds of success after a embryo transfer?
Well, with fresh embryo transfer, I would say the most important thing that patients need to remember is that we have to start progesterone supplementation on the evening of egg retrieval. Progesterone supplementation in a fresh embryo transfer, it's really important because we really want to prepare the endometrium for the embryo transfer that is going to happen either day 3 or day 5 into that cycle. In a frozen embryo transfer, progesterone is also very important. It would start either right after the lining check or on the day the embryo transfer takes place. And that depends on the type of protocol that you and your doctor decide to proceed with.
Yes, I agree. Progesterone is such a big deal when it comes to the success of an embryo transfer. And we talk about the progesterone because this is something that you can control. This is something that is within your ability to do a thing, right? As opposed to so many other things when it comes to fertility. In a fresh embryo transfer, you're doing this after a IVF stimulation. And we know that that stimulation and specifically the egg retrieval and poking into those follicles can lead to insufficient progesterone production. If there's not enough progesterone being made by your body, then that can really affect the endometrium, which is the lining of the uterus, its ability to be receptive or to be sticky, and will affect implantation or the ability of the embryo to stick. That's why we're so big on starting this exogenous progesterone, meaning starting progesterone medications right with the evening of the egg retrieval so that we can really support that luteal phase, that really progesterone heavy phase of the cycle to really optimize the endometrial lining for implantation and that early pregnancy maintenance. Starting progesterone after retrieval when you're doing a fresh transfer is super standard practice in the world of IVF.
Yeah. And speaking of progesterone, there is no specific progesterone protocol that is better than others. Vaginal progesterone is probably the most widely used formulation for luteal phase support or for doing progesterone after an egg retrieval when undergoing a fresh embryo transfer. Intramuscular progesterone, IM progesterone, or people like to call it PIO, is also very effective and might get you a slightly better clinical pregnancy rate compared to vaginal progesterone because you're trying to match the high estrogen levels from the IVF stimulation to the level of progesterone that you're taking. But it is limited by patient discomfort and, of course, the injection related side effects.
There's this really awesome study that was published in 2019 in Fertility and Sterility, which again is one of our favorite fertility medical journals, where they specifically looked at different progesterone supplementation for that luteal phase and what is going to be best to support a fresh embryo transfer. This was a big systematic review and meta analysis where they took results from a whole bunch of studies. They looked at 82 different articles, which included almost 27,000 women. And the study found that the clinical pregnancy rate was the highest in patients using intramuscular progesterone or the progesterone injections with PIO. The greatest benefit was really observed when progesterones were supplemented intramuscularly, those injections versus doing it vaginally. And that pregnancy rate was about 1.37 times higher than if you're doing it vaginally. So it was a significant difference. Progesterone injections, as we said before, they're not awesome. I would say nobody loves them. It's a big needle, not going to lie. It's tricky to do the injection in terms of the area and all of that. Our fabulous nursing team here at MFC has lots of tips and tricks for how to minimize discomfort when it comes to progesterone injections. If we're really thinking about ways to maximize success rates, to have the best possible success rates in a fresh embryo transfer, this is why our go-to is always the progesterone injections.
I think it's worth it at this point to talk a little bit about the emotional side of a fresh embryo transfer. IVF is a huge roller coaster. And actually, I was at Canada's Wonderland the other day looking at the roller coaster, being, yeah, that's pretty much what it is like. And with fresh embryo transfer, that roller coaster moves very quickly. You're going from injections and getting follicles to getting eggs to getting embryos to all of a sudden recovering from an egg retrieval to doing a transfer and hopefully getting pregnant all in a few weeks. Some people may love that and others may feel like it's too much and it's too overwhelming and they might respond better if they're just doing the IVF now, where it is a big deal, but the stakes are a little bit less because you're not actually trying to get pregnant yet. And then dedicating time later on to the frozen embryo transfer, which is when you're actually trying to establish a pregnancy. I think the emotional aspect is going to be high regardless, because let's face it, we're talking about fertility, infertility, miscarriages, really big things, your dreams of a family. So whether it's fresh or frozen, I don't think that you can avoid the emotional aspect of it. But I would say that I think it might be a little bit different just because of how quickly things are moving in one versus the other.
Absolutely. It's really different for every single person, right? For some patients, I think they really appreciate the ability to get to transfer sooner rather than later and to just know, right? Like, what's the conclusion? What's the answer? Did the cycle work? Did it not work? And for other people, taking that bit of a break, taking a bit of time, allowing emotions to cool off, allowing hormones to cool off can really be very, very beneficial, and to take that break. And I think, it's really about knowing yourself and what works best for you. At the end of the day, I really hope that in this episode and our previous episodes, we've really gotten across this idea that there is no straightforward answer of what's better, a fresh transfer versus a frozen transfer. It's a very complex, nuanced question. There's pros and cons of each of these. And so taking that month as a break is not massively detrimental. You don't have to keep pushing yourself to a fresh transfer if you don't feel ready, if you don't want to. There may be some really great reasons about why we really want you to go for a frozen transfer instead of a fresh transfer, for instance, with that risk of OHSS. And so these episodes will give you a lot of great information, but there's no substitute for having that discussion with your physician and talking about what is best for you in that specific moment for that specific cycle.
Whether it's fresh or frozen, the goal is the same, which is a healthy pregnancy and a healthy baby. And only you and your doctor really know what your unique situation is and what works best for you. This is one of the beauties of this field of medicine, that there is no cookie cutter answers, that every situation is different. This is one of my favorite conversations to have with patients because it really solidifies this idea that you're not a patient, you're a person. And the decisions that we make for you to help you achieve your dreams have to take into account not just the science and the randomized control study, but who you are and what are you feeling and what are your risk tolerance and what are the things that will help you feel like this journey was about you and not about guidelines or study or research. And at Market Fertility Center, we really value that. That's really important for us as physicians to always take into account the entire picture to make a decision that it's about you. It's always about you.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramir C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.